Good evening, everybody. Our next speaker is Dr. Gigi Chen. She is a medical oncologist and gynecology cancer specialist with Diablo Valley Oncology. And for Dr. Chen, if you have any questions for her, please use the yellow cards, and we will collect those at the end of her presentation. Dr. Chen, welcome.
Thank you, Margaret, and thank you all for coming here tonight. So Dr. Lerner has given us an overview of the surgical aspects of the gynecologic cancer. I am a medical oncologist at Diablo Valley Oncology, and what I try to do is to cover the chemotherapy or new treatments for the gynecologic cancers, as well as to touch upon some of the genetic testings and screenings as well. So who is a cancer survivor? An individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. The family members, friends, as well as caregivers are also impacted by the survivorship and are also included in this definition. For our cancer survivors, it's not that you live, it's also how you live. I'm going to start by talking about cervical cancer, and then I'll talk about ovarian cancer, and then followed by uterine cancer. So as Dr. Lerner had said, cervical cancer is the third most common gynecologic cancer. In 2013, in the United States, it's estimated that 12,340 new cases of cervical cancer will be diagnosed, and about 4,000 women will die from cervical cancer. Cervical cancer was one of the most common cause of this cancer death for American women, but because of the screening that we have, the death rate has declined by about 70% between 1955 and 1992. And average age of diagnosis, 48 years. HPV is diagnosed in about over 99% of the cervical cancers. And against the subtype of HPV, 16 and 18 are found in over 70% of the cervical cancers. Early cervical cancer is frequently asymptomatic. People may have abnormal vaginal bleeding or postcoital bleeding, may or may not have a visible or palpable lesion on examination. So I think one of the advances over the past few years was the development of HPV vaccine, which was developed to prevent infection of some of the HPV subtypes that are associated with cervical cancer. Predominantly, they provide immunity to the HPV 16 and 18. So it's exciting to have that. I think we can also do better. This is the a map of the percent of the adolescent girls who received 3 doses of HPV vaccination. You can see that in California or in the western region, the percentage is about 25 to 32% that are receiving it. So I think we can certainly do better and prevent this disease furthermore. So in terms of treatment, very early stage are treated with a hysterectomy. If patients with high-risk features at the hysterectomy, then they may benefit from additional treatment, such as radiation or chemotherapy with radiation. And higher stage patients are treated with combination of chemotherapy and radiation. The role of chemotherapy is to make the radiation more effective. So in this last year, at the American Society of Clinical Oncology meeting, there was a new drug that's being incorporated that's to treat advanced cervical cancer, and that's bevacizumab, or known as Avastin. In this clinical trial, about 450 women, they were randomized to, with advanced cervical cancer, they were randomized to either chemotherapy, or Avastin plus the chemotherapy. And what it showed was that the combination of the chemotherapy and Avastin caused improvement in terms of response rate, as well as the time to keep the cancer away for longer, as well as an overall survival benefit as well. So that was quite exciting. And the way the bevacizumab or Avastin work is that it cuts off the supply of the cancer, cuts off the blood supply to the cancer by shrinking the blood vessels. Therefore, the cancer regress, as shown in this picture. So now we're going to switch gear to ovarian cancer, and Dr. Lerner has talked about some of the cancer statistics. Estimated new cases of ovarian cancer in 2013 in the United States is about 22,240. So lifetime risk is about 1 in 72, and average age diagnosis is 63. 5 to 10% of the ovarian cancer are familial, which could include ovarian cancer alone, or ovarian breast cancer, ovarian colon cancer. So treatment of the ovarian cancer includes a combination of surgery as well as chemotherapy and targeted therapy. Chemotherapy are IV, intravenous drugs, or oral drugs, or intraperitoneal drugs. These are drugs that are given, and the goal is to stop the cancer growth by killing the cancer cells or stop them from dividing. And there's a number of them that are available for patients with ovarian cancer. And you can see it's many drugs have been approved since 1964 to now. The most common ones we use are carboplatin and Taxol, as you probably are familiar with. Now, it's exciting over the past few years for us to be looking at some of the new targeted therapy as well. And these are a newer type of cancer treatment to specifically attack cancer cells while to minimize side effect to our normal cells. So we had talked about Avastin a little bit for the cervical cancer. It is also, used or studied in ovarian cancer as well. Pazopanib is another drug that I'll talk a little bit more that stops the new blood vessel formation. This inhibits cancer growth. Another class of the drug is something called PARP inhibitors, which blocks DNA repair and also cause cell death from that. So there's a pathway called vascular endothelial growth factor, which basically is one of the ways causing the cells to divide and grow. And bevacizumab or Avastin is an antibody that catches these vascular endothelial growth factor and then causes the cells to stop dividing or growing. So that's one of the pathways. Another pathway is a PARP inhibitor, which usually, the PARP is important in terms of the DNA repair. And normally, if we inhibit the PARP part, our cells have a way which is mediated by the BRCA, breast, which is associated with the breast ovarian syndrome, and it repairs the cells so the cells survive. But in people who have the BRCA mutations, they lack that ability to repair. So the PARP inhibitors can be extremely, can be a lot more sensitive in patients who, for example, have the BRCA mutation. So that's an area that's studied more, and there will be a clinical trial, phase 3 clinical trial that's looking at this pathway as well. This year there was a trial that was presented which looked at 900 women who had surgery for ovarian cancer, completed chemotherapy, and they looked at them taking pazopanib, which is one of the drugs that stops the blood vessel formation to the cancer, and they compared it to the placebo. And what they found was that the pazopanib arm delayed the progression of the ovarian cancer compared to the placebo. Right now, the data is too new for us to know whether women can survive longer, from this drug. But over the next few years, we'll be able to have some of those more information. Okay. And also, there are a lot of interest in looking at cancer vaccine, which uses our immune system or uses antibodies that are man-made to try to target cancer, to shrink the cancer as well. Lots of active research in that. So the third type of cancer is uterine cancer, and it's the most common type of gynecologic cancer. It's estimated about 49,560 women in 2013 are diagnosed with uterine cancer. It includes uterine endometrial carcinoma or uterine sarcoma, which is more rare. Lifetime risk for endometrial cancer is about 1 in 38, and majority are at diagnosis are confined to the primary state, which are early stage, and a smaller proportion spread to the lymph nodes and other organs at the diagnosis. So in terms of new advances, we're looking at chemotherapy after the surgery, or radiation, followed by chemotherapy, to figure out which is the better way in terms of preventing cancer coming back. And there are, a number of active research that's done at Jalmir through GOG. A little bit about the hereditary cancer syndromes, and these few slides actually are from Margot Thielander. She's the genetic counselor at Jalmir, and she's wonderful. So a few type of genetic syndromes that are associated with gynecologic cancers, including the hereditary breast and ovarian cancer syndrome, which affects the ovarian cancer, Lynch syndrome, which affects people can develop colon, endometrial, ovarian cancer. Also, a third one is something called Cowden syndrome, which people can develop breast, thyroid, or uterine cancer. And I want to talk a little bit about Lynch syndrome, which is associated with endometrial cancer. In these patients, there's a high risk for both colon cancer as well as endometrial cancer, and also some risk for ovarian, stomach, urinary tract cancers as well. About estimated 600,000 people in the United States have Lynch syndrome, but only 5% are really aware of that. So now there's a lot more awareness in terms of cancer, looking at patients' risks and looking at the pathology when a woman is diagnosed with endometrial cancer or colon cancer, to see what's the likelihood for her to also have the Lynch syndrome. And I think that's especially it's very, very important for that patient as well as their families as well. A little bit about the hereditary breast and ovarian cancer syndrome, the BRCA1 and 2 genes. So some of the characteristics of the hereditary breast and ovarian cancer syndrome, including ovarian cancer in the patient of the family, early age at breast cancer diagnosis before age 50, family history of breast and ovarian cancer, or bilateral breast cancer, patients of Ashkenazi Jewish descent, and either breast or ovarian cancer in the family, or male breast cancer in the family or patient. So those are some of the things that we look for, to screen to see if a patient is at risk for the breast ovarian cancer syndrome. And what we would do if a patient, has genetic counseling or testing that's tested positive. So the things that we can do to prevent cancer is increase surveillance. We would incorporate MRI into the breast cancer surveillance. We also would consider chemoprevention, for breast cancer, or risk-reducing surgery, such as salpingo-oophorectomy or mastectomy. And some of the long-term effects of the treatment for the chemotherapy surgery could include fatigue, pain, weight gain, hot flashes, chemo brain, or inability to work or loss of employment, and changing personal relationships. I think in Europe they did a survey where they sent the surveys to 8 countries. These are ovarian cancer patients, and asked the patient what are 3 things that they really thought affected them the most. And the answers were, one is that they wish that there's a therapy that does not cause alopecia or hair loss. They wish that there's better ways to deal with fatigue, and they also, wish that there are, more effective therapies. So those were the top 3 things that people have commented upon. For a cancer survivor, we would emphasize on healthy lifestyle, and Allison will talk about more, and Dr. Altman will talk about a lot more about sexuality and hot flashes and all that. We asked our patients to eat well, stay at a healthy weight, exercise, stay active. So I think that's the end of my talk, and thank you.